Thank you, sir. The chair, the president of Diabetes India, Dr. Arvind, dignitaries in front of me, Professor Das, Professor Sahai, then Dr. Jarver is here. हम पे मुश्तरका है एहसान गमे उल्फत के इतने एहसान की गिनवाऊं तो गिनवा न सकूं. So I'm really obliged for this, Dr. Banshi and the members of the governing body, Dr. Vasant Kumar, Dr. Joshi, all these people to nominate me for this oration. When I look at my predecessors, the people who are in the front row, I stand a mile apart from being an academician. I've been a schoolmaster, primary school teacher of medicine. So, but it's just all the love and affection of these people. I have known Dr. Shaukat Sadikot for last 35 years. By chronology, he was 1 year junior to me. And we would be talking sometime, interacting in between the API session and some of the diabetes meeting. And then he'll say कि देखो मैं तो ब्रांड मेडिकल कॉलेज का स्टूडेंट हूँ भाई, ये मॉलिक्यूलर बायोलॉजी वाली बात बेकार की बात मत किया करो हमसे, ये तुम बनारस वाले जानो. But then one of the qualities which he had, and it brought me very closer to him, and Dr. Banshi is instrumental to it, is to appreciate the need of the common medical practitioners who did not get an opportunity to do MD or DM or DNB and have been practicing diabetes. So he brought all these people under one roof, gave them a platform, created an opportunity to interact with people. His predecessor, Professor J.S. Bajaj, was a different personality who became the IMA president. And all these people would remember Professor J.S. Bajaj. And all these people also remember Dr. Sadikot. What a wide difference. One was at a different mode, another was at a different mode. A common MBBS graduate student cannot dare to ask any question or talk to Dr. Bajaj. But at the first year practitioner passing out doing internship have the courage to discuss anything related to the practice of diabetes with Dr. Shaukat Sadikot, and that was the greatness of him. So thank you very much. Reason why I chose this subject about the gap junction connecting TRL receptor in cardiomyocyte. Because all of us have been worrying why come these people of diabetes, and there have been autopsy study to support normal coronaries, normal ejection fraction, good control of diabetes, still people succumb with the cardiac heart disease. So we had a couple of paper research work which we did, and initially I was quite reluctant. I asked Dr. Banshi, why did you choose me? Because to be an orator or just like this, such a function, I don't deserve. He said, no, because of you contributed the textbook of diabetes, Sadikot International textbook. You are the right person. This topic I kept initially reserved for the research meet in the Pune. But he said, no, you keep it for this. And this is the reason, if you look at the part of my presentation, I have two people sitting in front of me, Professor Das and Professor Sahai. They have been examined for my PhD students, and some of the publication goes back to those chapters. This is a cardiomyopathy because we have a problem, the heart failing. Initially we thought heart fails because of hypertension, or fails because of the valvular disease. Failing heart because of diabetes only is a very late phenomena. In last 30 years we recognize this. And this is because of the structural changes. It could be because of the functional changes. Could start from the simple ventricular dilation, a systolic failure, or a LVH, a diastolic failure. But the cause behind this is the fibrosis, the cardiac myocyte fibrosis, and the fat consumption by the lipotoxicity. And that's the core reason why this starts. This is what we call a syncytium myocardium. The cardiac myocytes do not have a barrier. They communicate each other. And they communicate with a what we call pacemaker potential of minus 90 millivolt, the resting potential, minus 70 millivolt, the triggering potential. And together, it is communicated through the fast quick channel moving sodium ion, and that ion is through the connexin, one of the pore, the micropore which permits. So it's the metabolic perturbation, it is the autonomic dysfunction, sudden cardiac death. We remain totally unaware of why this happened to the diabetic patient, and we have an answer today. You will get the answer why it happens. Then we have a microvascular dysfunction, and then together interstitial fibrosis, which is due to protein glycation and extracellular matrix accumulation. The mechanism starts from the hyperglycemia, which is the beginning part. I'll talk in a moment how it happens to. Then we have a lot of pro-inflammatory cytokines, and then ultimately the collagen deposition. And this is the advanced glycation end product which is responsible. So this is because of the involvement of the mitochondria. And before mitochondria gets involvement, the endocytoplasmic reticulum. So it is a mitochondrial dysfunction because of the impaired mitochondrial dynamics, autophagy, which is very well known in the field of diabetes, the mitochondrial OGLC and acylation. I'll talk in a moment about this one, and then the subpopulation mitochondrial and the permeability transition lead to contractile dysfunction. I'll go quickly to this slide because of this is difficult slide, but the hyperglycemia primarily leads to cytokine and RAS activation, the collagen fibrotic tissue deposition. There is a stiffening of the myocardium, and then dysfunction starts. I'll make it things a little more complicated by this slide. I kept it in the last, and look here at this particular part. This is the traditional hexokinase pathway. Unlike the EM pathway, the glycolysis pathway. In hexokinase pathway, you also generate one, it's called UDP and acetylation glucosamine. It is the protein. You take the protein, you take the glucose, you heat it in a test tube in high school, and you get a glucosamine, hexosamine conversion. But what happens here in this particular, this is the GLC and ISAs overexpression reverse coronary endothelial dysfunction in type 1 diabetes. And this is the connexin 40, a sweet connection between connexin 40, the microchannel which is responsible for this encapsulation. So what is connexin? This is protein of cardiac myocyte cell gap junction. Now today we know how come this syncytium myocardium so quickly transmits, and right from the first day in the embryogenesis, cardiac myocyte, they evolved from the mesoderm. We have a lateral plate mesoderm, two lateral plate mesoderm, we have a central plate mesoderm, and this identifies one embryonic cell to commit as the endothelial function, and then this is responsible for the conductivity, rhythmicity, automaticity right from the day one. This is the essential protein, hexameric, and creates a low resistant channel. That's why sodium channel is a so quick channel, and then it's a key regulator in the transmission of electrical impulse. This is the N terminal, this is this carbonic C terminal, and this is the EC loop, and then we have two cell 1, cell 2, and this is the hexagon, this is the hexameric tubes through which the transmission occurs. And this is your first year MBBS Hodgkin Huxley knowledge that we have this pre-junctional cardiomyocyte, you have a post-junctional cardiomyocyte. In between the two, you have the channel through which communication passes, and this each hemi-channel connection has a 6 sub-connection standard, and from where we have the conduction of the cell. We have two connexin 43 and 40 which are isomers, distribution in intercalated disc. Turnover increases in the cardiomyocyte. The moment injury occurs, the turnover increases. During acute inflammation, and this is the story trying to bring the two. which is responsible for the pro-inflammatory cytokine stimulation of C643 in recruits new lymphocyte. So this is ultimately what happens. You have a smooth cardiac myocyte cell, you have a fibroblast, and you have a myofibroblast. And then you have this is the AV node, the bundle of His. This is the cell which is responsible for the destruction of the communication, the conduction, the endothelial dysfunction, and the cardiomyocyte dysfunction. All three would initiate right from the day one. The day you have a hyperglycemia induced dysfunction of the mitochondria and endoplasmic reticulum, much earlier than the gross changes would occur in the vascular endothelium. You have already changes pre-existing in all the three: the endothelial cell, the communication system, as well as the cardiac myocyte. This I wanted to tell you, and this probably you will be able to comprehend better when you take the experimental animal here, and you increase the concentration post strepto injection, and the animal becomes diabetic, streptozotocin induced. This is C640 expression, this is 43 expression. And as the expression increases, these are the histogram, then this is the PR interval increases. Look at the control, look at the 7 days, look at the 30 days. And gradually the QTC prolongation occurs, the PR interval becomes very large, and these patients, almost animal develops something like what you have know, the complete heart block. There could be AV dissociation. And therefore, the sinoatrial node, there is no expression, so primarily the heart rate regulated by SA node through vagus nerve is not involved in spite of autonomic dysfunction. What you have, the AV node involvement with C640, 43, 45, endothelium cell almost 7, atrium 40, 43, and then Purkinje fiber. So connexin is important communication gap which it would regulate not only the ventricular dysfunction, not only the endothelial dysfunction, not only the microvascular complication, not the microvascular complication, but it is the cardiac myocyte dysfunction and the fibroblast which is responsible. And look at the dysregulation of connexin 43. This is the normal glucose, high glucose, and look at the 37, it is normal, 40, but 43 is one. This is the normal glucose, high glucose. The C43 expression is down-regulated in the diabetic patient. Now we'll talk on the TL receptor, which is an innate immune response. And these are the responsible to regulate with the combination of gut myobiota, which is responsible for pathogenic mechanism of diabetes, as well as obesity and lipid accumulation. We have series TLR1, 2, 6, 7, 8, which is working on the cell membrane. This is the cell membrane bilipid layer, and the signals working at the endosome. I was talking to you, this is the communication disease. It starts from three places. One at the cell wall, second at the endosome, third at the mitochondria. So it's 1, 2, 3. So entry of the sodium is hampered at the cellular level. Then the transport of the energy at the mitochondrial level, the place where we have a burning of the glucose, and last the endoplasmic reticulum. This is in type 1 diabetes. This is called DAMS, damage associated control of the cell. The moment any cell is damaged, then in response to this, we have a lot of cytokines being secreted, and they are mediated TLR4 and then TLR2, and they are responsible for damage of the beta cell in type 1 diabetes, and that could be one of the reasons of the manifestation in related to the diabetic complication. So connecting this story, this is the receptor at the cell wall, TLR2 and 4 receptor, producing the changes into the RNA, producing what called microRNAs, MIR 105, 143, 19AB, and these are the biomarkers now to pick up the early beginning of the pathogenesis of diabetes in type 2 diabetes and TL2 receptor. This is the endosomal area where the TLR3 is responsible. So endosome, the wall, the mitochondria, and the cell. All three are related with toll-like receptor associated damage and is responsible for the pathogenesis of type 2 diabetes. This is the obese, this is the TRR4 regulate cardiac lipid accumulation in diabetic heart in non-obese diabetic mouse, and this is the model, NOD, not obese diabetic, as well as TRR4. And look at the number of percentage of diabetes over the weeks in the experimental animal, and they are responsible for the development. So the neonatal high oxygen exposure, even in like this is like type 2 diabetes, dysglycemia, would be responsible for left ventricular dilatation, increased TLR4 expression, and hypertension. And when you use the drug like TLR4 antagonist, and we are developing this drug, this is soon going to be in the market, they would counteract the left ventricular hypertrophy as well as the blood pressure. The last few slides, this is look at this is a very complicated slide why I wanted to tell you the right from the TR1, 2, 3, 4, 5 up to 10. This whole family, these are the longer one, this is the normal glucose, NGT, and these are the different stages of the diabetes, and look at the number of the expression which increases over the period. So now to build up this story together, this is the liposaccharide induced degradation of the connexin 43, so TLR4 are involved at this, as well as the connexin into the junction. Cell wall, junction, communication together with the delay into the expression of the C43 would be responsible for many glycemic induced damage. And this, now everything together, this is the experimental proof, C43 and TLR4, look at their expression in relation to different stages of diabetes and in the pathogenesis of the type 2 diabetes. Therefore, to summarize, toll-like receptor are class of pattern recognition receptor that initiate the innate immune response. They play the pivotal role in recognition of damage-associated molecule, I told you in the beginning, which occurs in type 2 diabetes. The expression is increased in cardiac myocyte damage much earlier than vascular endothelial damage in diabetic patients. And this is the take-home message. So what we have to do as a molecular biologist, what is we call translational medicine, people are now concentrating on developing molecule earlier than these three. They would be cause of the cardiovascular complication. So early than any one of these damage, the changes do occur. 40 and 43 connexin are gap channel molecules which play active role in modulating cardiac myocyte injury, response for conduction, SA node disease, Purkinje fiber, and ventricular wall damage in diabetes. Overexpression of both connexin 40 and 43 leads to arrhythmia. So this is the reason why some of these patients develop sudden cardiac death and ventricular asystole prior to macrovascular and microvascular complication, prior to endothelial complication, prior to dyslipidemia. These patients could develop TNS activation response for beta cell damage and activating pro-inflammatory cytokine leading to insulin resistance. Together, overexpression of TLR4 in decreased expression of connexin 43 activates human cardiomyofibroblast in diabetic, and now they are target in developing newer drugs to prevent cardiovascular complication in diabetes. And I have one news which I transmitted to Dr. Banshi also one, that even the older drug like tolbutamide have a potential working on these TLR receptor and connexin to transform some of these alpha cell into beta cell. So you have a lot of scope in future. Therefore, even a primary school teacher talking the biochemistry and the membrane biology at the very lower level could ultimately affect the outcome. We should appreciate all these teachers, our teachers, biochemistry teachers, physiology teachers who taught us, make us worthy of it, and then we became the celebrity in treating diabetes. Again, thank you very much for electing me for this oration. As I said, I have been a very small man. The credit goes to these people, Banshi, Dr. Das, Dr. Sahai. They have been examined by PhD students. And some of these papers are related to our PhD work in which we have worked on connexin and toll-like receptor. Then we've been published. I have the communication to Dr. Sabu, and you can look at those papers. Lot of potentials. But again, thank you very much for inviting me.
Thank you so very much, sir.